Welcome to the ASN Kidney Week podcast, exploring the latest advancements, research, and trends shaping the future of kidney care. Tune in for expert conversations, clinical insights, and highlights from ASN Kidney Week, a go-to source for staying informed and inspired.
Hello, I'm Julie Ingelfinger. I'm a professor of pediatrics at Harvard Medical School and pediatrician and senior pediatric nephrologist at Mass General Hospital, and spend much of my time as a deputy editor at the New England Journal of Medicine in Boston.
Hi everyone, my name is Hiddo Heerspink. I'm a clinical trialist and clinical pharmacologist based at the University of Groningen in the northern part of the Netherlands. I've been involved in clinical trials in nephrology for many years, and it's my passion. I'm very pleased to join you today.
Yeah, I'm Rich Lafayette. I'm an adult nephrologist at Stanford University, where likewise I'm very passionate about clinical trials, and we're at the Glomerular Disease Center, and I'm so happy to be here in Houston at the ASN.
And I will add that I'm happy too. I'm not a trialist, but I'm happy to look at them and criticize them.
That's the wonderful nature of editors, right? You can criticize, but also improve and move things forward. So it's much appreciated.
That's kind. As many people say, if you're an editor, the best thing to do if you want friends is to get a dog.
There you go. Fair enough. So again, I'll take on that. Again, it really is great to be here in Houston. I got to arrive before the meeting started. Had great pleasure in participating in the glomerular disease pre-course. And then today's been a wonderful opening day, and I really enjoyed it. Both of your participations and presentations. It was great also to participate in the plenary session. I think the overall tone from Prabir Roy-Chaudhury's opening address to your comments, Julie, the presentation of new data is that really it echoes the presidential address that this is a time not only of great optimism, but of true progress and getting new interventions to patients who really desperately need them. For decades, we were really a society focused on replacing kidney function and trying to have patients deal with that. And now we're really looking at preventing the loss of kidney function, and I just find that entirely very exciting.
And perhaps even curing kidney disease, right? This is such a positive time, and that was the tone of this morning. We can change the course of the disease, and the appeal that it has, and the question to the audience, step in nephrology, help us to continue this positive atmosphere.
I would add that at the point at which I was a medical student at Albert Einstein, we had a transplant program, and what I remember most of all was how desperately ill the patients who came through were. And I particularly remember a wonderful young woman who had gotten a transplant, and she was a school teacher, 5th grade, and she really said that her hope was she was going to be made much better, and her dream was not only to return to teaching, but to have children. At that time, though I wasn't very far along in my medical journey, I thought, oh, I wish that were realistic, but it will never happen. And it didn't happen for her. She did not do well. But now, many of the patients I've seen over a very long period of time have been restored to a very normal life and have had children. And today was exciting for me, thinking about the fact that many people with kidney disease might be found sooner, and that progression would be prevented.
Yeah, indeed. I again, just to carry back, I think it's remarkable that there are so many efforts to improve dialysis, and there's roadways being explored during this meeting. That, just as you said, transplantation today is very different than it was decades ago, with really wonderful outcomes being achieved by patients. But again, ideally to prevent the progression of chronic kidney disease or even the onset of chronic kidney disease is so much more attractive. And now I think all of the decades waiting to really see results from studies in genetics and omics and stem cells that had led to when's it going to come, and when will it translate to intervention medications to work. Now we're there, and all that hard work is paying off. And again, at a meeting like this, to see young folks and very established professors all alike really still committed to that basic science and then trying to translate it into clinical programs and clinical care. Having our community of nephrologists, patients, and all the allied professionals really working side by side. It really is wonderful to see, fresh breath of air, and I think this meeting will be full of lessons like that.
And Richard, maybe the data that you presented this morning is part of what you just said. Starting with the biology, and now you have the results in a large patient population. Maybe you can tell us a little bit more about this data that you presented.
Yeah, thanks, Hiddo. And again, I think it just revolves around that it took decades to really understand the pathophysiology and what the real targets to interrupt disease process can be, and who knew 50 years ago that we would identify things called APRIL and BAFF, and that if we could really safely interrupt immune cell function and really specifically move down galactose-deficient IgA in a safe, well-tolerated way, and move patients who would be predicted to lose 10% of their kidney function in 1 year to be absolutely stable. So I think it's wonderful. And turning it back to you, we've had old-style agents for blood pressure control and diuretics, but to really clean them up with the finerenone story, you should take us further there in terms of how impactful that can be.
Yeah, we presented this morning a study in patients with type 1 diabetes and chronic kidney disease who have not received any new therapy for more than 30 years. And although we've focused a lot on type 2 diabetes and chronic kidney disease, we have left patients with type 1 diabetes and chronic kidney disease behind. Many patients asked me over the last 5 to 10 years, when we presented data from SGLT2 inhibitor trials, can I now start using SGLT2 inhibitors? But these trials were all done in type 2 diabetes. So today we present new data from the mineralocorticoid receptor antagonist finerenone in type 1 diabetes, and we demonstrated that just like in type 2 diabetes, finerenone reduces albuminuria. Unfortunately, we didn't do a hard outcome trial which requires 5,000 patients, because that's almost impossible in type 1 diabetes and chronic kidney disease. But with the epidemiological evidence and also the progress we've made on an epidemiological level, knowing that albuminuria can now be used as a validated surrogate endpoint, it can be used as a bridging biomarker to translate evidence from one population to another population, we did this study using albuminuria as the endpoint and demonstrating that finerenone in type 1 diabetes reduces albuminuria and, importantly, can be safely used in that population.
Yeah. Indeed.
What do you think, if anything, are the brakes one might put on it in terms of looking at a bridging biomarker? Because the populations are not exactly the same. There are many sources of data that say things are clear enough so that it's reasonable to look at a validated biomarker. But what are the things you think about as a trialist that make you worry at all?
Yeah. So we used albuminuria in this study as surrogate outcome bridging biomarker because we knew that the effect of finerenone in reducing the risk of kidney failure in type 2 diabetes was explained for almost 90% by the reduction in albuminuria. And that gave us, and not only us, but also the United States FDA, reassurance that if you would see a reduction in albuminuria in a population where you think that the disease pathophysiology and the role of albuminuria in that disease pathophysiology is the same, you can use albuminuria as your bridging biomarker to translate the evidence from one population to another. But if you would have a drug, for example, SGLT2 inhibition, where we know that the effect of SGLT2 inhibition on the clinical endpoint is only explained by the reduction in albuminuria for 40%, you know that albuminuria in that situation is not the perfect bridging biomarker, and that you have to search for other options and trial designs to assess drug efficacy.
I think that's well said. As I look at it from the point of view of a pediatric nephrologist, when there are things that we as a subspecialty keep saying, we know that depending on what happens during gestation and in the perinatal period, people will have a different nephron endowment. And our field has been saying that, and Brenner and others were saying that your glomerular and nephron number is terribly important. That's great, but how can we look at that clinically and easily? There's not an easy way to do it yet, but my thought is, and I wonder what each of you think, is that looking at renal functional reserve is something that can be done, but it's not easy to do it in a study. You need to give some sort of stimulant to glomerular filtration rate, such as amino acids or a protein load. That would be very expensive in trials, and different centers might do it differently. And yet we need to think about that, because from my viewpoint, I see children and I look at them, say I see 20 children who were small for gestational age or born prematurely. I know that some of them, probably 20% at least, will have progressive loss of kidney function more quickly. And if they have a challenge, such as developing IgA nephropathy, or develop type 1 diabetes, they will be more at risk. But who are they? And I think if we could find them, it would change the trajectory, save many years of productive work and so on. And I don't know if you've thought about that. I think a passion of mine is trying to convince you guys who see adults that we need to find ways to see who's at risk much sooner.
Yeah.
And I think that would really take things to an even higher level.
Yeah, and I think sort of clinically, we're so far away from even identifying people with established disease. To find people who are at risk for disease still seems a bridge a little bit too far. But as you said, I think modern era, and I know there's lots of abstracts in this meeting, are looking at ways to further define kidney reserve, kidney function, to get non-invasive ways to evaluate how much nephron mass and glomerular number there actually are. And people have tried, as you well know, different imaging modalities, MR spectroscopy, doing a limited biopsy and trying to extrapolate from that. As I said, infusing proteins or other things that should increase GFR and see what happens. So I am completely aligned to try to identify ways to be proactive rather than reactive at the time when someone has a disease and they're declining rapidly, it may be too late. At the same time, sometimes pragmatically, I still am hopeful that in the other direction, that we're going to learn so well how to, with a pediatrician here, baby kidneys and really take care of them when they're under stress. I think a lot of the omics and physiologic studies together might tell us how to use different hormonal systems, interrupting them, how to eventually get to truly antifibrotic agents and make a slightly weaker kidney more resilient to injury. So I think we have to walk all these paths and hopefully we can do a better job.
But from that early identification point of view, I think this is the right time to do it. We have multiple interventions that are safe, and thus now it's the time to early identify the patients at risk of progression. And as one example, in the Netherlands, we have started a large screening program in all adults in the Netherlands older than 50 years. And we're going to measure the albuminuria to assess the prevalence of CKD, to assess the rates of progression, to assess the cost effectiveness over a national screening program. And And in addition, we've started another program because we know that the risk of mortality in people with CKD equals the risk of colon cancer. In the Netherlands, we screen all adults for colon cancer. These people are collecting feces, and now we've asked them to also collect just a little bit of urine for screening of CKD, along with the screening for colon cancer. So there are initiatives, and we hope to spread these messages also.
Yeah, and that's been a huge barrier, particularly in the United States, where you have the United States Preventive Health Services, and they've denied payment for screening urinalyses. And it makes things really, really difficult, even to look just for dipstick protein or dipstick blood, which is not a very expensive test, because the issue is that it then engenders false positives, and that can lead to imaging, biopsies, etc. But I think we can do a better job. We can still find ways to better risk assess patients. We know, as you mentioned, there's populations of children and adults who have obvious risk factors for kidney disease, and to at least get the screening to them would be a wonderful step. So just as you said, all this science, all this new pharmacology, all the new changes we know to do in diet, exercise, lifestyle can be achieved.
Yeah, and we have to think about access and affordability, because we can afford these new medications, but not everyone around the world can afford them. And so we also have to work on access for implementation.
I would agree on that. And certainly one of the things within this past year that's been really interesting for me is the studies that have been done looking at Shippaway, which is a cohort study looking at children with normal and slightly high blood pressures, and looking at them over time. And these are not children with horribly worrisome hypertension, but just slightly high. Following them over time, what has been found is that end organ damage can be found subtly and very early. I think seeing that and seeing the data from that study and some other recent ones suggest that changes in physiology, changes in vascular tone, changes in mentation occur very early and can be picked up without a lot of invasive studies. So I think our mindset really needs to change over the lifespan. And as a corollary or something separate from that, I would say that the field of nephrology and hypertension, which I sort of see as one thing, should more and more offer studies as patients are found with a diagnosis, not say, as has been said too often in the last decades, well, things are fine now, we really don't need to treat you, we'll just follow you along.
Yeah. And now the time is here.
Because we can offer something.
Exactly.
And the other thing that was said is we don't want to worry people. They've got something, but they're fine now. I think that's really wrong thinking.
Yeah. So overall, very positive start of the Kidney Week this year in Houston. There's a lot of optimism, new data presented, new ideas being generated, because we're still not there yet, but we are on the path towards a better future for patients with kidney disease.
I think that's true. I would wonder what you think, Hiddo, about using the knowledge that's being gathered in multiple quarters of the mechanism of different conditions. Certainly with IgA nephropathy, that's a big one, but one can look at much rarer conditions like nephropathic cystinosis and know that we know the pathophysiology of what's going on. And why don't more groups screen known medications or compounds not currently thought of as medications as something that can alter the pathophysiology early?
I foresee that in the next couple of years, more and more people will start doing this. We have now a menu of new therapies for different types of kidney disease, and I'm quite confident that people will then also start trying these new medications in certain diseases where they think that the mechanism of action of the new intervention could be applicable, it could be applied for these patients. So I think that the next years we'll see that question that you raised, Julie, will be answered by new clinical trials.
I think it may, and I actually see the beginning of perhaps a tidal change in that in my work, because I'm at a journal and people will call and run things by us, I've had patients call just out of the blue and say, I've been going online and I'm thinking, is there something? I was reading about X, Y, or Z, and what if there were something on that so-called pathway that could change the amount of blood or protein in my urine, or might be something I could do, so that there is the beginning of people who are thoughtful but aren't in medicine or science saying, there must be something we can do. Who are saying, I want to be proactive. I don't want to wait until I go to my internist in 10 years and the person says to me, you only have 32% of your kidney function left. I want to do something now before the clock runs out on me. And I think that means that as trialists, as clinicians, as basic scientists, we need to be thinking along those lines and have an attitudinal change that might be very positive.
I think it's a fantastic example, and it illustrates how patients are partner in this research and science. Because what I've learned over the last couple of years, we have more and more patients who are being involved in setting up clinical studies and executing clinical studies, and the insight and the feedback that they provide are really important. And this is another example how important the patient view and the patient perspective is, that they should work together with it. We haven't done that, but we are doing it now. It's very
I think that's so important, and I suppose I have the spectrum of time on my side that way, because when I was a student, I worked one summer as a nurse's aide in a small community hospital. And the doctors seemed awfully paternalistic and nasty even. They didn't want to hear from the patients. Patients were kept in the hospital a long time. The results of tests weren't discussed with them. Or if it was a tumor, they were told, we got it all. And thank goodness that is now a time of the past. And what we need to realize is that everybody does the best they can. But by walking together and getting buy-in from patients of, I want to know everything I can understand, and as we don't know what the best thing to do is, we need to work towards studies and trials that will make the outcome different. It's been really interesting to talk and hypothesize, and I would say anyone listening to this, what we would encourage you to do is think positive, think proactively, and think creatively. There are the tools in our field now to begin to have real progress and more hope than there's ever been for people with kidney disease.
Thank you also from my side for listening. We have had a fantastic start of the Kidney Week this year. We have more days to come. There will be more podcasts over the next couple of days. So tune in, keep listening if you are not here, and you will receive the latest updates from Kidney Week Houston 2025.